Okay, so hi everyone. Can everyone hear me? Can you hear me at the back? Show of hands? Great, perfect. So good afternoon, everyone, and thank you for joining us today to commemorate Martin Luther King Day by talking about the important topic of confronting racism in health. My name's Tanisha Spratt, and I'm a senior lecturer in racism and health in the Department of Global Health and Social Medicine here at King's. And I want to start by thanking the following groups and people for all of their hard work and efforts in putting together this important event for us today. So firstly, thanks to the Department of Global Health and Social Medicine, also the Anti-Racism Steering Group, which is based in the Department of Global Health and Social Medicine, and the Equality, Diversity and Inclusion projects and partnerships here at King's. Also, thanks to the following people. Firstly, Professor Anne Pollock, who was instrumental in putting together this event for us today. Amy Moore, Emily Williams, and Deborah Meredith, our wonderful Global Health and Social Medicine students, Tolu, Amediong, and Chanel. And thank you all of you for being here and coming to this event. It's going to be amazing, and it's going to hopefully generate some much needed and important discussions. We're not expecting a fire alarm today, so if you do hear a fire alarm, please exit via the way that you came in, through the front doors. And bathrooms are located in a different part of the building, so if you come in and turn left again, you'll find the bathrooms there. So we are very fortunate to have with us two incredible speakers with a range of expertise in public health, clinical practice, and strategic organizing. Camara Phyllis Jones is a family physician, epidemiologist, and past president of the American Public Health Association, whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of our nations and the world. Her allegories on race, racism, and anti-racism are celebrated for illuminating topics that are otherwise difficult for many people to understand or discuss. That racism exists, racism is a system, racism saps the strength of the whole society, and we can act to dismantle racism. Professor Jones is currently a commissioner on the 3-year O'Neill Lancet Commission on Racism, Structural Discrimination and Global Health, a visiting professor at King's in our Department of Global Health and Social Medicine, an adjunct professor at the Rollins School of Public Health at Emory University, and a senior fellow and adjunct associate professor at the Morehouse School of Medicine. Professor Jones previously taught at the Harvard School of Public Health and served 14 years as a medical officer at the U.S. Centers for Disease Control and Prevention. As president of the American Public Health Association, she launched the association on a national campaign against racism that catalyzed the first wave of what are now 267 declarations that racism is a public health crisis. And this was made by local jurisdictions, including city councils, county commissions, state legislatures, and other bodies. Since then, Professor Jones has been invited to engage in extended residencies as a Radcliffe Fellow at Harvard, a Presidential Visiting Fellow at Yale, a Presidential Chair at the University of California, San Francisco, and a Leverhulme Visiting Professor in, again, our very own Department of Global Health and Social Medicine at King's. Graham Lord, Graham Lord is the Senior Vice President of Health and Life Sciences here at King's. He is also the Executive Director of King's Health Partners and the Chief Academic Officer and Board Director at Guy's and St Thomas's and King's College Hospital NHS Foundation Trusts. Professor Lord was previously Vice President at the University of Manchester and Dean of the Faculty of Biology, Medicine and Health. He was also a consultant transplant nephrologist at Manchester NHS Foundation Trust and Executive Director of the Manchester Academic Health Science Centre. Professor Lord qualified in medicine from Cambridge. Following clinical posts at Oxford, the Hammersmith Hospital and Imperial College, he was appointed as a senior lecturer and honorary consultant specialising in renal and transplantation medicine. As an MRC clinician scientist, he undertook postdoctoral research in fundamental immune cell biology, including a 5-year appointment as a visiting fellow at Harvard University. On his return to the UK, he established the Department of Experimental Immunology at KCL and was the director of the NIHR BRC from 2012 to 2019. Professor Lord's clinical academic interests include multi-organ transplantation and the immunogenetics of transplant survival. He also has a long-term interest in academic healthcare systems and how they can drive improvements to human health in an equitable and sustainable manner. Okay. So just a note on format today. So this event will begin with each of our speakers providing their opening remarks, and we'll then move into a wider discussion on racism and health between our speakers. And at the end of the discussion, there'll be plenty of time for Q&A, so please think of questions and save them until the end. But for now, please join me again in welcoming both Professor Jones and Professor Law.
Well, good evening, and I'm so happy to see all of you here, despite what to me is very cold, because I'm not living here anymore. I live in Atlanta, Georgia. In my first 5 minutes, was torn between describing how I, as a family physician, PhD epidemiologist, molecular biology undergrad, came to be devoting my work to naming, measuring, and addressing the impacts of racism on the health and well-being of our nations and the world. And that's a very interesting story. But I decided that if you're interested, you can ask me in the Q&A period later. I want to jump straight to the chase, go straight to the chase, if you will, and talk about why you and I and we, as people who are interested and engaged in the health endeavor, should ever consider racism as part of our mandate or addressing anti-racism, all of that as part of what we do. So those of us who are busy day by day, trying to protect, preserve, promote the health of individuals and communities, most of us would say that we are committed to achieving health equity. And I define health equity as assurance of the conditions for optimal health for all people. And as a value statement, I think most, if not all of us, could agree that we should try to get there. And furthermore, there are 3 principles for achieving health equity that I have decided. I'm sure we could generate 100 principles just in 5 minutes for achieving health equity. But these 3 core principles are necessary for anything that's going to move. One is valuing all individuals and populations equally. The second is recognizing and rectifying historical injustices. And the third is providing resources according to need. And so when I describe those 3 principles for achieving health equity, a values kind of proposition that we all would support, it becomes clear that racism is a huge barrier to achieving health equity in my country, the United States, and I would say here. So you might be confused, what do I mean by that? So let me define racism, what it is. Because sometimes people think about racism just as interpersonal interactions. That is not the case. So I am going to say a 1-sentence definition of racism, and then go back and see. And then if my 5 minutes will be over at the end of that, that is fine. You can just let me know. Okay. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks, based on what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. So the important parts to pick up in that definition are, first of all, that racism is a system. It's not an individual character flaw. It's not a personal moral failing. It's not a psychiatric illness, as some people suggested, although it can manifest in those ways and many more. But in its essence, racism is a system of power. And a system of doing what? A system of doing 2 things, I said. Structuring opportunity and assigning value. On what basis is the opportunity structured and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks in a race-conscious society. You could, here in the UK, you're going to say, oh, no, we have 18 categories we can pick from to self-identify, right? But did you know that there is a police categorization that boils down to 6 categories? Like if you report something or if they can't ask you how you self-identify, then you go to the IC, the identification codes, I think it stands. So are you Northern European, Southern European, Black, from the Indian subcontinent, other Asian, Arab or North African, or just don't know? Look, so that thing, that IC code, which differs from the 18 categories, which that was another whole thing, because when you look at how the 18 categories are listed on forms, there's some kind of values proposition even in how they're listed. But that is the same thing that I am describing as socially assigned race in the US. That is the social interpretation of how one looks in a race-conscious society. And that race has profound impacts on the health and well-being of all of us. It is the substrate on which racism operates day to day. The three last things that were part of my definition, and then I think I will close and turn to you, Professor Lord, who we're now going to call each other first names, so don't be upset when we start calling each other first names. The third aspect of that definition, well, actually the fourth, because it's a system, does two things based on what? So-called race. The fourth thing is that racism has three impacts, not just on health, not just in education, not just in housing, not just on all of the things that, employment, all the things that the Commission on Race and Ethnic Disparities in 2021 documented the differences, but then said racism has nothing to do with it. We'll come back to that too at some point. But racism has these three impacts. It unfairly disadvantages some individuals and communities. But every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And even outside of the advantage and disadvantage, racism is sapping the strength of our whole society. The waste of human resources, how it divides us one from another, and how it even divides some people from their own interest. And we are seeing that big time in my country, the United States. So without any further comments, I pass it on to you.
Thank you. So, Professor Jones, Camara, and Tanisha, thank you very much for that kind introduction. And Camara, I'm humbled to be with you on this panel because of your vast experience. And as your bio was being read out, I thought, oh, I shouldn't really be up here with you. But anyway, so thank you for sharing the platform with me. And I guess recent events, I think Dr. King very famously said, the arc of the moral universe is long, but it bends towards justice. But actually, I kind of think we're waiting a long time, and it doesn't look like it's bending towards justice right at the moment. So that's how I'll frame my opening comments. So I'm just going to say kind of who I am, why I'm here, and what will the outcomes be. So why am I here? And I guess because I sit across our health and care providers, and I have a level of, I guess, in a hierarchical system, some levers of influence and power in the university, is sort of what am I going to do with that? And this really, my journey here, I started here in sort of beginning of September last year, and I was having a discussion at the King's Health Board's annual conference with Julia Gillard, talking about misogyny. So Julia, for those of you that don't know, used to be the Prime Minister of Australia, and she's now leading in our university the sort of Global Women's Leadership Programme. And somebody phoned in and talked about ethnic maternal outcomes in the Black population. So what are you doing about it? And I hadn't ever really thought about it in these terms before. This was 2 weeks after my new job. And I said, yeah, because our health and care system is structurally racist. And as I was saying it, I hadn't sort of planned to say that because it was a question from the audience, which is why actually these conversations are so important, because all of the things about the golden thread for King's Health Partners just dropped into place.
And stay near the mic, I think. Can you all hear him in the back?
Thanks, Camara. I'll stay near the mic. So that's my journey here, because I was originally a molecular biologist as well as a physician. So again, it feels right that I'm speaking about this, but clearly I don't come to this with lived experience. I've always had a commitment to health equity. I established a Centre for Health Equity when I was in Manchester, and how we pull together all the various strands of inequitous outcomes in healthcare. I've also done a lot of work living and working in America. I've seen the American healthcare system up close and personal with my kids, and the way that, that healthcare system is also, structurally racist. Let's be honest about it. And these are very difficult conversations. I've also done a lot of work with the government in Kenya about how do you provide universal healthcare access to your population. And clearly there are massive issues of structural inequality within Kenya, but also differences between the US and the British view of healthcare disparities in black populations. And then personally, I'm a transplant doctor, and the way that organs are allocated is also not fair and is structurally racist. And I keep coming back to this. And so what are we going to do about it? I think, as I said, sorry, I'm disappearing. Sorry. I think the US election and, the new president, I'm sorry, we agreed that we could get into this because I think it really puts these things into focus now. A week ago on Martin Luther King Day, and we saw over the weekend the rescinding of the NIH statement that clinical trials need to be representative of the populations that they serve. That's gone. That went on Sunday night. These things are very frightening occurrences. And so really I'm here to try and listen and understand what are the differences between the US and the UK, but also how do we define areas of action? So it's not just how we discuss these issues. What can I do within my span of influence and power to make a difference in this space? And I think the three things that we're working on within King's Health Partners that are relevant here, you'll have seen actually only last week, the COVID inquiry that looks at the disparate outcomes related to race, and the increased death rate in black populations, and other non-white populations, which frankly shows a lack of trust that populations have in our healthcare system. And as a doctor trying to do my best to care for patients, that's really a difficult thing to hear, but it's true. There's a huge lack of trust in our healthcare system. You look at our maternal outcomes that I referenced early on, maternal deaths and perinatal deaths are 4 times higher in our black populations than in our white populations. There was, the Ockenden report 4 years ago making this a statement, and then it was repeated recently that had showed no change. So even recognizing this means we're not actually taking the actions required to change it, to move from equal access to healthcare to equitable outcomes. And that's a very, very different concept that has been made very clear to me. Hypertension. Why should a young black man present in the emergency room with a cerebral hemorrhage as his first presentation of high blood pressure? This is what we're seeing. Is it because of lack of trust in the healthcare system for screening? How did we get to where we've got to? How do we recognize that, understand it, and how do we move on? And so, as I said, I'll finish now, but I'm really here to listen, to understand, and also to support what it is that we need to do to end this structural racism in our healthcare system, and also other forms of exclusion, and also really to be held accountable, to come back to say, okay, we had this really important discussion. What did I do about it, and what did my organisation do about it? I think equitable outcomes across all of our populations, particularly populations that are affected by structural racism every day, are really going to be the golden thread running through our new King's Health strategy that we're in the process of writing now, that will start in April. And again, we're going to challenge ourselves, with your support to deliver change. Will it be difficult? Of course it will. But actually, I'm here to be accountable for that to you and also to the patients and populations we serve in South London. And if there are things that we can discover through research or through implementation that are relevant beyond South London and around the world, then clearly we will share them as well. So I will stop there and I'll hand back you to Tanisha.
Wonderful. Thank you both so much. I'm just going to hold this here so that you can definitely hear me. Thank you both so much for that. I wanted to ask if we can start by reflecting on the civil rights movement and the ongoing need for racial health justice. So really thinking about the past and kind of moving that into the present.
So, before we do that,
yeah, sure.
there were some things that I wanted to pick up on.
Yeah.
And I don't know, I'm sure you had things you wanted to pick up with me. I am so happy that this inquiry is pointing out the disparities. But I was wondering, I haven't read the results. Was the main conclusion about trust?
So, in terms of the maternal health outcomes and the outcomes around hypertension and the outcomes of organ allocation, that wasn't the conclusion of these inquiries. These inquiries really just spoke to putting out the disparities, not really why they've arisen. So I think there was it was essentially around clinical outcomes. And I think to Tanisha's point, unless we understand how we got here, I don't think we're going to figure out where we go from here. And so that was a personal reflection as my practice as a physician. And that, patients have said this to me. I'll give you a particular example that I will never forget, that we had discussed before. When I was here in a former life, before I went to Manchester, I was sort of the professor of medicine chairing our grand rounds because I'm a transplant physician as my day job, or it used to be my day job. And we were talking about all the great work we were doing in organ transplantation, kidney transplantation, and pancreas transplantation. And I was talking to the organizer of the event, who I spoke to every week. I did this every week. And she was a black woman, black Caribbean woman from London. And she said, I came in and sat at the back of your presentation. And it's great what you're doing. And I said, and she started talking about donation rates in black populations in London. And she said to me, my children wouldn't donate organs. And I said, why? Why is that? And she said, because they wouldn't trust that the organs wouldn't be taken out before they were dead. Mm-hmm. And I can't forget that. And I think that is the lack of trust that many communities have in our health and care system. And so really, that's how I've distilled part of the challenge around that for me as a physician.
So I will, in the US, there's, especially around the time of the COVID pandemic, and there were, we didn't have vaccines yet and all of that, there was an issue about trust versus trustworthy institutions. And I think that your observation is true. I mean, she told you that her children, so she told you that her children did not trust the system. This is true. But the question would be, why? What do you do about that? So you have to make the institutions more trustworthy. and so you have to, so it's not, I had the reaction I did, the question, because often if we observe the lack of trust and stop there, we might think, oh, we need to make those trust us more, as opposed to understanding why there is the lack of trust. And so what is it about our past practice, and I'll get more into past, present, and future. What is it about what's happened in the past, in the UK, in the US, around the world, in terms of medical practice, in terms of experimentation, in terms of all of that? What is it about current practice? Because a lot of people don't know about the past practice, but they know that they were disrespected when they went to the surgery the other day. And how do we engage? How do institutions not just try to figure out how do we become more trustworthy, but engage with communities in real conversations about that? It's an invitation to do more, and an invitation, and then I'm interested, and an invitation to recognize that health is not the result of the health sector. The health sector is the ambulance, is the last Band-Aid. So our health status doesn't result from that, which also gives, like you're thinking about action. I am so loving this opportunity, I have to say, to talk to him, right? Because he can do, right? All of us can do. All of us have power, but he can have, like, pen power,
Yeah. Yeah. I'll put it away. I'll get out. Yeah.
No, I lost that. I lost the end of it. No, but it's about working with communities, trying to figure out it's about the health sector, not just even doing the interventions within the health sector. It's about, at the time when the U.S. Centers for Disease Control and Prevention was trying to do work on adolescent health, but they refused to declare 100% high school graduation as one of their goals, because they said, we don't control the education sector. But clearly, 100% high school graduation has everything to do with health. So in your role, not only reaching out to communities, but being willing to say, yes, we certainly need to do things where we have our hands already, where we have the people working already. We need to figure out, what do our clinics need to do? What do our hospitals need to do? What do our people need to do? But also, we need to engage with communities and be brave and connect with other sectors and join in their efforts as well. I see the overlap. So is that something that's going on already?
Yeah, I mean, your point is really well made. And we know that, what you might call the social determinants of health, very little of what I do in a hospital system is maybe about 20% of the outcomes are, if you want to just in terms of the numbers, of what happens in a hospital or even in a GP practice in primary care. It's mostly related, 80% is related to good housing, secure employment, good education, and feeling part of their community. And so we're already working with Lambeth and Southwark and the other 4 boroughs in South London very closely about how do we provide good housing, how do we open the skills agenda so that people come to, because we're anchor, the hospitals, the 3 hospitals I represent in the university, and the councils and the primary care practices employ tens of thousands of people, as well as looking after 3 to 4 million patients. So those anchor institutions, how do we work through the skills agenda so that kids in our communities that might not see themselves working in a university or a hospital have access to that, and then they're supported. So we're working very, very closely, and I have weekly meetings with the head of Lambeth and Southwark Council to put a plan together for how we turn this into action. So there's absolutely that going on. It's really important that we don't just have a biomedical model of practice. And I think, again, as you said, in terms of understanding, I think I go back to your very important point, Camara, that you made about individual trust and then trust in institutions. And I think because of the history, particularly in the US, in terms of experimentation, the very, very famous, infamous, I should say, case in the 40s
right.
Of penicillin treatment, or rather lack of penicillin treatment, to observe the natural history of syphilis, was understandably extraordinarily damaging. And the way that COVID, the vaccination, program and clinical trials in COVID were performed. I think in the UK, I think there was one COVID trial that we did in the UK that had, 1% of the population that were non-white. And then we say, okay, come and get your vaccine. And I think the medical profession has had multiple chances to try and address these things, and we just keep making the same errors. I think the final thing I'll say is to your point about community. So I've talked about hierarchical stuff so we can sit around with our pens and sign. I'm not going to say signing executive orders. We might get into that in a second. So I've got a pen, but I'm not going to throw it into the crowd afterwards. He did? No, he throws his shop. After executive order, he's throwing it into the crowd. Let's not go there. So we're working very closely with our community groups. So we go out into our communities. And when I say we, these are people in my team, and I do as well, to say, how can we work with you? And I think one of the things that also struck me is that, if you like, the commissioning of research is often not done in partnership with communities. And this is what, in my listening mode, this is what I've been told. How do we bring communities in to help us determine what research gets commissioned? Because otherwise, it's people like me and that work for me and across our organisations that are almost like sort of doing research to people, and we're deciding what research gets done. And I can only begin to, I can't even begin to imagine, when you start with a lack of trust in individuals, lack of trust in institutions, and then we can't say, we're going to do this research on you because we think it's a great idea. Is it any surprise that people won't participate or trust the outcomes of that research? So I think how we've got to and where we need to go to I think there are multiple levels here. We're doing our best to address all of them. But, I need to listen about how we do it better and how we do it quicker, because I think we know what to do. We're just not doing it.
May I, before you go into, I don't know how much time we have. So when I was president of the American Public Health Association in 2016, so now, 9 years ago, and, you described it in my bio, I launched our association on this national campaign against racism. I want to describe, because these three core tasks that I proposed at that time are now what I recognize to be the three core tasks of anti-racism as a process anywhere. Mm-hmm. And because there is a willingness here to be about anti-racism, to be on a panel about racism and health, the first of the three core tasks is to name racism, to say the whole word. And I say that because we have to name any problem in order to get started on a solution. And when we talk about what's happening in both of our countries, there, racism denial is staunchly held by many, and it's also very seductive. And what we see, all of these executive orders, all of the Supreme Court decision about, students for fair admissions versus Harvard in 2023, in the U.S. context, moves against critical race theory, moves against teaching history, moves against diversity, equity, inclusion, which have found their genie in our current president now in trying to take away those efforts. All of those are manifestations of racism denial. Mm-hmm. So it's not a new thing, but it's, talking about Dr. King and what he says, the fierce urgency of now would say that we need to address that. So that is why naming racism continues to be the first task of being anti-racism. If we leave this room and we said, we just went to a talk on racism and health, and then don't say the word racism ever again, like, what was that? Right? So we have to all, even in the United States, again, still say the word racism. But as important as it is to name a problem in order to get started on the solution, as important as it is to put racism, the whole word, in the strategic plan that you guys are writing, to put it in your, wherever you put things. It's necessary but insufficient. Because of what you said, so powerful, we have to move to action. Naming a thing will get you a little bit, it'll put things on agendas, but if you don't act, when that thing is on the agenda, what are you doing? And so the second of the three core tasks is the first part of action, which is to ask the question, how is racism operating here? Where the here is within your reach, right? So you have a big reach, so you can say, how is racism operating here at King's Health, all of that. Or I, as a parent, might say, how is racism operating here at my child's preschool? Or, we could say, how is racism operating here in my classroom, or whatever? How is it operating in this country, in the world? But when you ask that question, you're asking it because you don't want your anti-racism actions, which we all say we have to move to action, but we don't want the anti-racism actions to be wild, untargeted flailings. We want to do some landscaping. We want to identify promising targets for action, promising, levers for intervention. And how do we find those? I'm going to say a thing that if you're not a policy wonk, you're going to be, oh, don't blow my mind. But I'm going to say it, then I'm going to explain it. We have to look, the mechanisms of racism, of structural racism, are in our structures, policies, practices, norms, and values. So then you go to your committee room and you say, okay, we're going to look at structures, policies, practices, norms, and values, and people will be like, I'm out. I can't do that, right? It sounds hard until we recognize that each of these things are the elements of decision-making. Mm-hmm. Structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, what's on the agenda and what's not. So I'll go through all of them, but then I'm going to say, what you can do as a convener is change who's at decision-making tables. Okay. If structures are the who, what, when, and where of decision-making, policies are the written how of decision-making. And most times when people try to look at structural racism, they only look at policies. And they don't even look at what policies aren't there. They just look at the policy. It's instructive to do that. But then practices and norms are the unwritten how of decision-making. Practices, how we do things today. Just look at me. You'll see here and now, this is how we do things. We don't have to write it down. Norms, how we've always done things and how we expect you to do things going forward, deeply embedded. And we said structures are the who, what, when, and where. Policies are the written how. Practices and norms are both time scale different, but part of the unwritten how. Values are the why of decision-making. And it has been my experience that say you asked me to come talk about spaceships, and I'm going to do a talk for you about spaceships. The day before, if I think about spaceships and whatever you're doing with spaceships, I can think about the who, what, when, where, how, and why of decision-making and identify for you 4, 5, 10 targets, early targets for action if you want to be about anti-racism in your spaceship endeavor. So I think that exercise is quite useful when we think about action. So that's the second thing. First is name racism. Second is ask how is racism operating here, looking at the elements of decision-making. Mm-hmm. The third is to recognize we have individual power. So now we say, well, I think it's such and such. We have individual power to ask questions and challenge people. We have individual power to put things on agendas. We have individual power to mentor students or hire people, whatever. But as much individual power as we have, what we need to do is organize and strategize to act, because collective action will amplify whatever individual power we have. In your situation, I am so sorry if I'm sounding really preachy now.
No, good. I've noticed you all day. Homework. You're doing lots of homework. Keep preaching.
But I would say even that organizing and strategizing to act is to go with other institutions or with other sectors or whatever, but especially with communities. The one, if anybody, the next time you sit at a decision-making table, or you set one, your first question should be, who is not here, who has an interest in this proceeding? And then your job is not just to represent those interests, although you might have to do it in the short term, but your job is to really create space at the table. And therefore, the easiest to identify intervention for how is racism operating here is to change who is at decision-making tables, because the who will bring the what is on the agenda, And we'll also bring the values about prioritization and investment. So when we had the earlier conversation about engaging with community, you're doing that already. Just think about at which decision-making tables are they? Can you bring them to other decision-making tables? Can you ask, can I come to your decision-making table, to the community, right? Like they don't have to always come to you. So that's it for right now.
We're going to bring up questions at the end, if it's okay, just in the interest of time, but I will come back to you. And that's actually a wonderful segue into the next section, which is thinking about the present. So considering our current political climates in both the UK and in the US, what does racial health justice look like today?
Oh, gosh. As I said at the beginning, I sort of lived and worked in a number of countries, and so I know, or I thought I knew a bit about the US and the UK healthcare system until last week. So I think this is a timely discussion because I think it brings into stark relief what racial justice in healthcare doesn't look like. I think we're seeing it evolve in real time. And I think it's incumbent upon us to, draw a line in the sand and say, this is not us. I think we also need to acknowledge, and these are very difficult discussions now because it gets into politics and everyday action now, is that certainly on the university side, you see this in the US and the UK, the side of the argument that you might want to call, is it progressive or what? I don't want to give things labels, has been kind of weaponized against us. And you see the overwhelming, democratic mandate in the US because of that. So it's how do we, come together to combat that with an understanding of the political reality that we've just seen play out. And again, you can't separate politics from racism because it's, one drives the other and, over history. Is that if we don't almost confront it now with concerted action, to your point of community action, AI very much, I'm terrified about what's going to happen in the US. And I think you can also see those changes happening in this country as well. And you can see them happening across all of Europe. So I think we're at a sort of tipping point in geopolitics that will have profound negative impacts on racial justice. So how we align about action that we make sort of common cause with partners across the globe is absolutely fundamental. And I don't know the answer to that. So I'm genuinely here to listen to see what assistance I can give to the direction of travel that we need to start to undertake to bring about action. And I really don't know what that is at the moment. So again, that's why I started out with Dr. King's quote. I'm feeling quite, down about this. And and also, to call it out, I'm a sort of white guy sat on this panel. I have no lived experience of this. And so getting into this space and this discussion, I think's quite important because I can do things. But you're absolutely right. We should have people at the table that have that lived experience, that can have those values. And I very much see that as part of my job and how I do that. But I guess it's just how, and it's also not, it's what do I do with that? Because I have the opportunity. But I just think we're in difficult times. And I think we need to, again, come together as a community to just draw a line in the sand and say, not here.
Yes, I agree with you that we are in very difficult times. It's very scary. In 1 week, how things, it's supposed to be a shock and awe thing, I think, against people who believe that we all have value and that. So one of the things that we can do is notice inaction in the face of need. I have started thinking that that is a hallmark of how racism often manifests. That is, lack of action in the face of need is pointing to racism. The racial and health justice and all the justices things, I'll go back to the 3 principles for achieving health equity, valuing all individuals and populations equally. But now I'm going to do a crosswalk between these 3 principles. I'll say them now so you can remember them, and then I'll go individually. So the 3 principles were valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. That's not just for racial justice, that's for social justice, health justice, that's for human things. These are 3 principles. If we didn't know what body we would be born in next, you know, like if you wanted a fair chance for everybody, not already knowing what body you were born into, and then feeling entitled to privilege or really sad and devalued. So these 3 principles is what all of us would want for all of us if we didn't already sort of have secured our position. Okay. Now, I'm going to do a crosswalk between those 3 principles. And Tanisha, I'm so sorry, because I know you said you want to be on the edge and you're just moderating, so I haven't been looking at you.
No, I'm very happy watching and learning. Yeah,
okay.
Keep going.
And what I describe as 7 cultural, societal, kind of values-based or whatever barriers to achieving health equity in the US, and I spent a year here as a Leverhulme visiting professor. So in the UK, I can speak to that, and really in most Western cultures and maybe in other places. I'm going to list the 7, and then I'm going to do a crosswalk between them because the values and the principles for achieving health equity are being undermined daily by these barriers. The first is our narrow focus on the individual, which makes systems and structures either invisible or seemingly irrelevant. It makes our sense of self very small. We may not even include our cousins and aunts and uncles in that sense of self. It makes us feel that we don't think there, but for the grace of God go I. We don't think we are all in this together. We don't think, you know, that I am my brother's and my sister's keeper. So this narrow focus on the individual, it even keeps us from understanding power. It makes us think that all of my power is in myself, and it makes us ignore collective action and collective power. Where I always say this, collective action informs us, it inspires us, it propels us, it protects us. But anyway, so that's the first, narrow focus on the individual. I know I don't have time to go through all 7 in that detail. The second is our ahistorical stance. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. And that is getting worse in the US context because they are changing the histories, merging the histories, banning histories, because they want us to be ahistorical. They, who's the they? The people who do not want a fair chance for everybody if you didn't know what body you were born into. So that's going to be my definition of they from now on. Okay.
Big father, you could call it.
Say it again?
Big father.
Oh, it is among, like, oh, yeah. The third of the 7, and I'll say the 7, then I'll do the crosswalk so that you can respond to the 7. Okay. The third of the 7 is our endorsement of the myth of meritocracy. The story that goes something like this: if you work hard, you will make it. I give you that most people who have made it have worked hard. Now, why didn't I say all people who have made it have worked hard? Because some people are born into royalty or money or things like that. But most people who have made it have worked hard. But there are many, many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by racism, sexism, heterosexism, capitalism, all of these things. So, and I haven't talked about how the definition of racism can be generalized to be a definition of any system of structured inequity. We need to go back to that in a minute. But so when we deny the existence and permanence, for example, of racism, then we blame those who haven't made it for being lazy or stupid. The fourth of the 7 key messages is our endorsement of the myth of a zero-sum game. If you gain, I lose. Oh my God, that's what's happening operationally in our country right now. It keeps us from understanding that these systems sap the strength of the whole society. It keeps us from cooperating to grow a bigger pie. The fifth is our limited future orientation. There are 2 things that I think of that we can touch today that will hopefully survive us. Those are the children and the planet. And we have a disregard in my country and perhaps here for the children. We don't ask how are their children doing? We don't care. We don't think about a 7-generation sense policies. And we have a usurious relationship with the planet. The 6th of the 7 is what in the US I call the myth of American exceptionalism, which really we mean United States of American exceptionalism, right? Because, Canada and Mexico and Central South America, all America. But we call it the myth of American exceptionalism, which makes, and I understand that there's a myth of British exceptionalism, and there's probably the myth of Australian exceptionalism, and lots of German, so wherever you are, people have this myth that they are so deserving, so unique, so ordained by God that they can't learn anything from anybody else, and also, right, and that they are entitled to all the stuff they've grabbed and are holding. The 7th is actually the first, but I say it's 7th so you can hear the other 6. The 7th barrier is white supremacist ideology. What do I mean by that? I'm not trying to have people stand up and stomp out. No. It is the false idea of a, oh my God.
No, that wasn't me.
That was you.
Keep going.
Keep going.
It's a false idea of a hierarchy of human valuation by race. There is no such hierarchy. And the falser idea that, yes, there's a hierarchy and that will put white people as the top, as the ideal of the norm, but this white supremacist ideology in my country is making people who are living as white, because, people who have the same appearance in different parts of the world might be white one place and not somewhere else, black someplace, not somewhere. Okay, so that's the social assignment of race. But people who are living as white in the US, it gives them a sense of entitlement. It causes the devaluation and really dehumanization of people of color and fear at the browning of America that has resulted in our situation right now. Mm-hmm. Now, so those are the 7. Narrow focus on the individual, ahistorical stance, myth of meritocracy, myth of the zero-sum game, limited future orientation, myth of national exceptionalism and white supremacist ideology. Let's go back to the 3 principles, very quick crosswalk. Valuing all individuals and populations equally. Well, that white supremacist ideology flies in the face of that. We can do other crosswalks here, but the second one, recognizing and rectifying historical injustices. Being ahistorical prevents us from doing that. Also, this myth of a zero-sum game in terms of rectifying historical injustices makes people stop. Okay, we could go with a deeper crosswalk, but that's that. The third one, providing resources according to need. The myth of meritocracy. Well, why are you going to provide resources according to need? All they need to do is work harder and they'll get with it, goes with that. And also, again, the myth of a zero-sum game. So we can do that, but what I'm saying is, it's all well and good for me to pontificate about some principles for achieving health equity, but until we, and I don't know how to do this, I don't know if we do it in the schools, in the churches, in the communities, whatever, but until we actually acknowledge and address the wrongness of these barriers, even as we're trying to dismantle oppressive opportunity structures, even as we're trying to nullify dehumanizing value systems, but we have to also address 4 of these I call the roots of racism denial. The narrow focus on the individual, the ahistorical stance, myth of meritocracy, and white supremacist ideology. They are the roots of racism denial. We need to confront racism denial, and we need to anticipate and prepare for pushback. The 3 that are not the roots of racism denial are exactly about action. That is, zero-sum game impacts how we act, limited future orientation impacts how we act, and this sense of national exceptionalism impacts how we act. If we can figure out how do we maneuver around these, then maybe we will have a better chance. So.
fantastic. How do you, I'm not going to respond to that. I won't go through my 7 rebuttals. But actually what I'm, and hopefully I'm sure people are taking notes so that you're giving me the playbook that I can operationalize. I think calling it out and understanding, your sort of 4 roots of racism, I think that's what we're doing right now.
And I think the racism denial. Yeah. So racism is one thing, but the racism denial that characterizes both of our countries. Yeah. Yeah.
Yeah. And I think the Brits are actually quite good at this. I think we've manufactured this mythology in actually probably an even more sophisticated way than you do in the US, flitting between the 2 countries as I do for work. I think it's more overt in the US, and I think you're seeing that right now coming out in full bloom to make it easier to deal with. Actually, it's out there punching you in the face. So there's no doubt about, as you're talking about this white supremacist ideology, and you look at certain, people, supporting white supremacist ideology in Germany, in France, and in this country, it's very, out there in front of us now. So even if we wanted to ignore it, we couldn't. I think, there's more subtlety in the UK, but I think it's no less real and no less important to address. And as you say, understanding how we got here and then what we do about it is absolutely fundamental. And I think, sort of the older I get, the more importance I place on community, because community is almost the pushback to that zero-sum, everyone's an economic unit. And that if you're not, prospering in an economic sense or an academic sense, that you're just not working hard enough. I think this concept that it takes, a village to raise a child, I think we've lost that. And engaging with, not in the ivory tower of a university or in a hospital, is actually working with, listening to our communities and bringing them to the decision-making tables is something that can change the lens that we put on these things very, very quickly, and acknowledging the historical basis, as you say, of racism denial. I think it seems to me that we've moved back to a place maybe that we were, in the 30s. Mm-hmm. And I think, historical analogy is, you can sometimes, a few years ago, a few months ago, a few weeks ago, if you'd have said that, people say, "Oh, you're going to that old trope," and that's an easy historical illusion that actually doesn't bear too much close examination. But actually, the closer I examine it, the more it does. It just is sort of crystallizing in front of us, and our response to that is going to define who we are, both as individuals, as communities, and as institutions. Mm. And actually, I can't think of a more defining cause to address, because it will address everything else that is not right within our systems. And I think we need to, as a community, come together and show that together we can be a force for good. Individual action is important. It's individual daily action. But actually, I think it's, I was doing a graduation ceremony last week in the Royal Festival Hall, which was fantastic. So I saw all of these, young students going out into the world with their scroll, and they'd done their medical studies or their, whatever it was they were studying. And there's a quote at the end of my speech that I'd not heard before. It was the first graduation I'd done since coming back from Manchester, and it was from Archbishop Desmond Tutu, who was an alumnus of this university. And he said, "Do your little bit of good where you are, and it's those little bits of good together that overwhelms the world." And actually, I think, I obviously a few minutes ago I went on I don't know what to do. It's all terrible. Actually, now that we're moving into the phase, what we do about it, I think if we move together as a community, then I think we can generate overwhelming power that can be a pushback to this dreadful, let's call it out for what it is, white supremacy. Let's call it out for what it really is white male supremacy. It's not just white supremacy, it's white male supremacy. And that's why, my opening comment that the health and care system is structurally racist is because it was made, designed and delivers for white men. And, we can do a lot around that. How do we change our educational curricula so that actually all of those, and I think our students are ahead of us on this anyway, which is great. So how do we listen to our students that we bring through? The university, we have 40,000 students at any one time. We have 250,000, 300,000 alumni around the world. That's a pretty powerful network effect as well. So we're not without agency. And I think how we decide to move forward with this is really important, addressing all of those issues that you call out, which I couldn't agree more with, actually.
I mean, you both really beautifully already answered my final question, which is how can we build towards more equitable futures? So thank you for preempting me. Did you have any final thoughts you wanted to kind of reflect on before we go to the Q&A?
One thing. So people who know my work, and some of you have known me when I was here before, know that I use storytelling, allegory, that I see images and then I use them as teaching tools for understanding something about issues of race, racism, anti-racism, healthcare. Something happened to me on Wednesday, so it was 5 days ago. So you guys will be the first ones to hear the baby germ of an allegory, but I think it gets us to the importance of naming and acting, but how? So here's the story. Here's what it is. It's not going to be beautiful, or I have no pictures with it. It's just going to be basic. This thing happened to me. Okay, then you guys can help explain what we're learning from it. I'm on a Zoom call with my husband and somebody who helps us with our finances, both of them in the US. So 3 of us on a Zoom call. I have my laptop in my lap. And a message comes across, low battery. Okay, it's not plugged in or anything. I'm on a sofa. So I go over to a table, put my laptop down, and I take the plug and I plug it in the wall. So 10 minutes later, in the middle of our Zoom call, I'm out, my computer dies. And I was like, oh. So then I say, oh, I plugged it in the wall, but I didn't plug it in my computer. So then I take the other end of the charger and I plug it in my computer. And so I'm back, and 5 minutes later, it dies again. And then I was like, oh, I didn't flip the switch on the wall. Right? Because I'm in the UK, like we don't do that. We are so economical, like in the States, right? I didn't do that. And then the rest of our call proceeded. This is what I make out of it, but you guys can take it. We can help build this into a big thing right now. That is that, first of all, it's important to know what the problem is. Your battery is low. So we're naming low battery or racism or something like that. So then we say, I can't just sit here like this. This requires the fierce urgency of now. Okay. So I got to do something about it. And I think it has to do with it. My battery's low, I need to plug things in. But I just, in my haste or my not thinking clearly, I plug one side in. I still had some juice, it was just low, it wasn't dead, until it went dead. Then it caused me to have to figure out, to reevaluate. It's a cyclical thing. This naming racism, asking how is racism operating here, organizing and strategizing to act. Once you do it once, you're not done. You have to go back and name racism again still. Oh, my computer died now. Then ask how is it operating here, and then organize and strategize to act. So then I plugged it in on the other side. So that should be it, because if the power came back in, I joined the meeting. I guess it turns out that little box in the middle has a little capacitance, something in it. And so it kept me going for 5 minutes. And then I died again. I thought I had solved it, right? I had to go through the cycle again. And I was like, what could it be? And now I have to really know, where am I? I have to know something structural about the UK and plugs in the UK and all of that. And then I do the thing. And then it was good. So I think that I'm going to expand it out to make it, a really nice allegory like my others. But I think this is about the importance of, we have sequential steps. We have to name racism, ask how is racism operating here, looking at these structures, policies, practices, norms, and values, the elements of decision-making. Then we need to organize and strategize to act. Maybe it would have been better if I didn't have anybody else in the house with me and the others didn't know what was going on, on the call. But I would have been better. Okay, so I'm just adding this. I would have been better if I had organized and strategized to act, because if I had gone to a neighbor, they would have said, oh, Camara, look, your thing is hanging out and you didn't push the thing. It might have been faster, right? Okay, but then I had to go again and again. And the main thing that I haven't had a really good story to illustrate yet, and this isn't a great story, is that this problem, the racism, the low battery, was a problem for all of us, not just for me. Right? The meeting could not proceed as fully without me there. And even though it was my problem that I was experiencing with my computer, it sapped the strength of the whole endeavor. So, did you get it? Yeah. Yeah. Okay, so you're the first to hear this. This is a baby allegory. I don't even know what the name of it is yet, but.
Wonderful.
Yeah, good.
Thank you so much. Yes, great. So this is now the Q&A portion. We have one question right here. It's on mute at the moment. So.
Okay. Thanks very much for your contributions. So mine is not so much a question, but a bit of a comment. Okay, so I work at King's. I'm a senior research fellow, been here since 2008. And I just wanted to drill down a little bit to, it's not just about confronting racism in health. It's also about healthcare research and the woefully low numbers of Black people that get an opportunity to conduct research in our academic institutions. And I can't begin to tell you, as a Black woman in this university, the barriers that I have faced over and over again to be able to speak about racism. I have not been allowed to speak about racism, and I can tell you that if I dared to talk about white supremacy in the all-white groups that I am in on an everyday basis, I'd be out of a job. And so these are some, and you do not know how painful that is. So my battery is very low. And why don't we get a chance to speak about what some of the issues are? White people have to speak on books. Sorry, why do white people have books? He flipped up. Sorry, the switch. But why do white people get to speak on our behalf about the health inequities and what we do about it? I want Black people to do that. And in our wider communities in South London, they've lost trust because they're sick of extractive research where white people go into those communities time and time again, take the evidence, never come back, and those people don't get to benefit. So I want to see more practical solutions. And I raised this last time, Camara, when you were up at the IOPPN. And every time I speak out plainly, there's a comeback. So it's not easy to speak about racism. It's not easy to be honest like I'm being now. But somebody's got to do it. And if I wasn't in the room most of the time, none of these things in my academic circles would ever be said. Mm.
Thank you.
You have to hold that one, right?
Yeah.
That's real.
Yeah.
Real.
That's not anything that's outside of reality, but what many visualize. See, I don't need a mic, do I? Is it there? I just had to hold and feel that one because it's real. I think, Mike, I don't know if it's actually it is a question. As we're moving this agenda forward, which is what I think this is about, it's about how do we move this forward rather than having these conversations going around in circles and we're still at the same place where we were yesteryear. That's not what it's about. For me turning up, for you turning up, I know. So I'm asking, so let me tell you what it is that I do. I'm somebody with lived experience of racism and of mental health challenges. One, I'm the NHS England's mental health equalities advisor that catalysed the development of the Patient and Carer Race Equality Framework, which is the first anti-racism framework from the NHS, right? Now, what that framework is about, and the clue is in the title, communities being involved in decision-making that concerns them, right? Communities being involved in commissioning services that involves them. Communities being involved in the service improvements or the service response to their particular lived experience of the symptoms of the impact of systemic racism from the cradle to the grave that leads to higher risk of mental health distress. That means that you end up in these settings which actually replicate the harmful experience that you have out there in the wider community. I'm consistent, and it's actually going. So for me, it's very hopeful because I'm about, you mentioned communities. I'm looking at you, actually. I know Camara, I don't know you. So you're here being accountable, right? And I hear you, and it's like, well, hold on a minute. I ain't seen you nowhere saying what about what. So I'm looking forward to working with you going forward, right? Is what we've got now is communities coming to the table to actually help to build trustworthy relationships with their counterparts. And there's people in here from, say, for example, South London and Maudsley, which was one of the pilot trusts for the PCREV, right? And the way, what we've got to is very different from where we were. So it is possible to build trust with communities because you're actually having them participating in the decision-making that it is that it's about their lives. I'm asking, how are we going to make sure such a similar kind of approach, building on, not starting from scratch, and everybody wants to start ground zero. We're not at ground zero. Let's build on what is working and apply that to other areas of healthcare. And what does King's want to do in relation to playing a leading role in that kind of participatory approach? Because it's a different social contract. We're no longer about people doing to people over there. You don't even know them, but you're doing to them, right? Now we're in the place of doing with, right? So here we have frameworks or opportunities of ways of doing that that could be successful. What's the opportunities that King seems to replicate that in other arenas and be a leading exemplar on that? South London and Moses' ambition is to be the leading anti-racism organisation, trust, by 2026. Can't do that without the people.
Thank you. Other questions? I can see we've got two. Let's go here and then here.
We've got some questions at the back as well.
Yeah. Oh, yes. Okay. Over here, but we can go here and then here and then here then. Okay, that's fine.
Sure thing. Okay.
Okay. I think the first point for me is what I would appreciate, and maybe other people here as well, is to have a response from the panel.
Can you hear her in the back?
Can you hear me?
Put it very close to you, or...
How about that?
No, is it on?
Some people are saying yes and no.
Okay, yes. Okay.
Green light's on. Okay, very close. Thank you. So the first point is that I would appreciate, and probably other people in the room would appreciate, a response from the panel to the first speaker. Because at the end of the day, that was said in a way that really does warrant a response.
Yes.
Rather than just moving on. So that's the first thing before I even get into, if you like, my questions and observations. Is that okay?
Yes. I will start, and I will say that thank you for your bravery, and that I understand that right now you're so isolated. And all I would say is I hope you can find people not right around you, but other people. I talk about, here's another of my allegories. Have you heard the one about the geese flying? No. So, when you see geese flying, V formation, flying north or south, whichever you go, the reason they fly in the V formation is because the goose at the front is blocking the wind for those who come behind, blocking the wind for those who come behind, and so forth. And I used to worry about that goose at the front. What happens when she gets tired? Does she fly off someplace random or drop to the earth? Well, in actual flocks of geese, what they do is that one moves back and another one takes turns. And what they do is they take turns in leadership so that the whole flock can move. You know, there's the thing about if you want to go fast, go along. If you want to go far, go together. Now, I know you are not the limit. You are absolutely not. You're trying to hold down the fort right now since 2016.
From 2008.
2000. Oh my gosh. Okay.
Now I'm not looking to stand back because why should I?
Why should you? But you are.
To be part of the leadership as a nurse woman. I have the right in this country.
And yet they aren't taking you seriously. And you are at risk of them kicking you off at their pleasure, although you're not that weak.
No,
you're not that. But you don't have to be. But they can come at some time. So what I'm suggesting is, it would be good for the unit to bring more people in. It used to be when I was at the Harvard School of Public Health. I was the only Black person in my department. When I left, they brought another Black person in the same office. When that person left, they brought another Black person in the same office. And I was like, oh, I understand why they only have one Black person at a time, because they only have one Black office. Right. So the answer to that for the bigger structure is cluster hires. You can't do that by yourself, but you could help her people do that.
And you can only progress. Because I've been waiting for a professorship for a long, long time. I'm just bringing a 2.6 million grant, and I'm very happy, but I need to be able to progress. And I'm not.
What is your name again? What is your name and what unit are you in? What is it?
Brown, Josephine Ogden.
Okay, and where are you located?
In my DPN.
Okay.
And you can find me reasonable.
Yes.
So let me respond as well. It would be, first of all, thank you for speaking out. It's not easy, so thank you. And let's talk and see how I can help. Actually, so congratulations on your grant. And one of the reasons for doing this event that Anne asked me to do is that we can not just start this conversation because we know what the issues are, but how we then move to action around this. So it's the start, not the end. And I want to be part of an organisation that values you and others in a very fair and equitable manner. And I don't want to be part of an organisation that doesn't have this as its priority. And that's what I've said, that as we're, pulling together our strategy, which we're launching, that this is a golden thread, and that isn't just. And I think you're absolutely right. I think your comment about extractive practices is nail on the head, and there's been a history around that and a lack of promotion for Black academics to participate in that. There are a number of programs of work, for example, that the Wellcome Trust is doing right now. Exactly right. But then how do we provide support? And also, the sort of the flying geese analogy is a good analogy, because actually I think you carry a lot on your shoulders as being isolated in your group. And I guess the question, and again, your point is right. What do I know as a white bloke sat up here? And the answer is, in terms of lived experience, I don't. What I can commit to is trying to do something about it as an ally, a supporter, whatever you want to call me. I do have, as you were saying, some ability to change things in a way that's sustainable and equitable and right. And that's what I'm here to commit to do. So thank you for your comments.
Thank you. in the interest of time, I'm thinking if we collect a couple of questions at a time.
So can I just get to my question very quickly now, please? Thank you, but that was important.
What you're saying is we won't respond. We'll just hear all.
Yeah, we'll just hear a couple and then,
fine.
yeah.
So I think the first is an observation, actually, that, just to Graham first and foremost, and then to you, Camara, when I'm not going to say we, when you are still using the language of non-white, that inherently has the effect of othering and presenting white people, the white agenda, as the norm. So that's the first thing. Language matters.
Yeah.
Carries, if you like, the reality of what many of us are here for and wanting to change. We also heard the word ethnic. And so, sort of what we say, how we speak the language, there's something about revisiting that. The other thing I would say, Camara, is please never apologize. You're not preaching. What you were doing, or what I was experiencing, was what Dr. King describes. Thank you for reminding us. The fierce urgency of now. We've been talking about this, the royal we, for decades. And can I say to everyone, honestly, this is the first time that I've stepped back into a higher educational environment for decades because of some things that we've spoken about. But I tell you something, being here, my commitment has been redoubled. I'm back. But my question is this. So what's the difference in racism, when we talk about racism in the US and the UK? It seems really important that we clarify what are the differences based on different historical contexts. Because at the end of the day, as a so-called Black British woman, what does racism mean to me in a way that it may be different to my African American sisters? That's an important thing because they're not the same, and we have to have clarity. The other question that I have, and I will finish, I think, here. So I've made lots of notes, and I would really appreciate to hear more about Dr. Martin Luther King, his vision, and the quote that we've got there. Because the key words for me are injustice, inequality in healthcare, but it's the most shocking and the most inhumane. This is not just a simple talking point or academic exercise. Lives are being lost. Mental health we've spoken about. This is the reality, and this was said, 77 decades ago? And here we are, we're still talking about it. And the final thing I would say, coming back to you again, Graham Lord, is I used to deliver training for children and young people's mental health for charity. And I used to leave my participants with one question. What is one thing that you're going to do different starting from tomorrow as a result of this? And so that's about taking action. Thank you.
Thank you.
Thank you. And we had one question right here in the middle, and then one at the back. If you could keep them short as possible, I'd really appreciate it, and then we can close.
Thank you.
Thank you.
Can you hear me?
Yes.
Yeah. So first of all, thank you for what you said, Graham, and thank you for what you said, Camara, and thank you for facilitating. So I'm on the board with Graham at Guy's and St. Thomas's. So we're both, I'm an exec, he's a non-exec. And it's interesting what you said. I was really interested that you said, why do you speak for us? Why are you here speaking for us? And I think what we can all reflect is sometimes people only listen to people that look like them. So I find that actually I can say a point and have my impact, but when Graham supports me or when someone else supports me, then it has more impact. So yes, why are people speaking for us? But I think it's acknowledging that when they do, then that's actually a helpful thing in terms of that allyship. So I really love that you're here and speaking and that you're passionate. But I think it goes back to when we go back, what's going to be different that actually is going to turn the dial for us and our communities?
Thank you. And our final question, just a gentleman over here in the blue shirt.
The one at the top has been waiting for a while.
Oh, okay. Okay, we'll do that one and then that one. Again, if you could keep it as quick as possible, we'd really appreciate it, and then we'll respond.
She wanted to, yeah.
Thank you. So having a black doctor improves a health outcome.
Can you hear me?
No, not well.
Sorry. Is it okay to go ahead?
Yeah, if you could just speak up a little bit.
Yeah, so having a black doctor improves the health outcome of black patients. But I read that in the US, there's been no increase in the proportion of black male doctors since the 1930s. And this is a very small proportion compared to the overall population of the black population in the US. So what are the things that can be done to increase the number of black applicants for medical schools and success within the medical field, both in the US and the UK? So a direct question to Professor Lord would be, what proportion of those graduates that you saw at Royal Festival Hall last week were of black background?
Thank you. Wonderful. And the next question in the middle?
Hello, can you hear me?
Yes.
Right. My question is, I was in Lewisham a couple of months ago, going past Lewisham Hospital, and there seems to be a huge health problem in the UK that disproportionately affects black people that nobody talks about. And I'm talking about kidney failure and kidney cancer. In terms of kidney failure, I saw the biggest queue for a dialysis machine, which was absolutely ridiculous. Is there something you can do, Graham Lord, head of service? Two things I'd like you to do. Obviously, we can't have these ridiculous queues of people standing in the street waiting for dialysis. But I think there needs to be a national campaign for people to volunteer to have a kidney. I have an Iranian friend. It's a common thing. He was telling me in his country for people to donate kidneys. We don't even talk about it here. So if you could raise the ante, I'm saying that on behalf not of just my community, but everybody, that we need to do something urgently about it. Thank you.
We'll invite responses.
So can I just jump?
Was there one more?
Oh, sorry, there's more.
Okay.
Sorry.
Yeah.
Okay. Yeah.
Thank you. My question is about, my name is Victoria Ngobo. My question and my bringing here tonight is about hemoglobinopathy, which is sickle cell, and we see a lot of inequality and injustice in the funding.
It's hard for me to hear everything, to hear every word. Yeah, just.
Yeah, it's about hemoglobinopathy and sickle cell.
Okay.
So the inequality, injustice, and the really shocking is enormous. I can't say it really, but what can we do to improve the funding, to support research, to support this group?
Thank you. Do you have capacity for one more question? And then okay, great. Final question.
Hi, I just wanted to mention something about the use of power. Can you hear me now? Yeah, about power. I was hearing, I think Graham was talking about action. And I think one of the actions you can do is thinking about, maybe I have to transfer that power that I have. It might mean that, you step back and include people with lived experience to kind of support the decision making. Sometimes that's what's really helpful. Doesn't mean that you're not a part of it. You're supporting, but you're actively using your power. And I think sometimes people with power in that kind of, when we're talking about systems of racism, it's about recognizing I have this power. I may need to do something else, and I need to use that space for somebody who can actually, who has that understanding. Doesn't mean that you don't. Yeah. Somebody else might have more understanding, and it's also about that, not because I'm in that position, because again, that feeds into racism because you have a lot of power. especially in the health services, if you're a doctor, what status that has in your decision making rather than somebody who's a lot lower than you.
Yeah.
So it is about having that awareness for yourself about what it is, what does racism mean, and how do I actively use my power to help to dismantle racism, because that's within your remit to do.
Great.
Thank you.
Yeah.
Thank you. Yes, please. Either of you would like to jump in.
Should I just give a quick, if I forget any of the questions, please come back to me. So if I start, I guess, with the last question. Yeah, I hear exactly what you're saying, and I wrestled with, would it be right for me to be on this panel or not? So, good challenge. I decided on balance that it was, because I had been asked to do it rather than it's something that, I put myself forward to do. And I talked to a lot of colleagues and friends about, did they think it was the right thing for now? Going forward, in 6 months' time, if we do this again, would it be better for someone else to be sat here that isn't me? Absolutely. And I think stepping away from this place to let, somebody else step in instead of me, maybe that is the right thing to do. So that's why I said I'm here to listen about how I can move this on. I think, so that's that question. I guess the couple of ones I'd like to come back to. One is, how do I, the question about dialysis in Lewisham. Obviously, I'm a kidney doctor, so I understand the increased incidence of kidney failure in black populations and the under-provision of dialysis spaces, particularly at Lewisham and Greenwich. So that's not a hospital that I have, that I'm on the board of. Actually, they are part of our partnership. So what I'll do, so thank you for that comment, and I appreciate it. It's completely wrong. And I'll pick that up with the chief executive of Lewisham and Greenwich and see what they can do about it. I'll commit to doing that for you. So thank you for bringing that up. I guess that's back to the question about what are you going to do that's different? Well, I'll do that tomorrow morning.
Either of you, yeah.
And I always find that the questions are more important than the answers. So I don't have tick by tick, answers, but I have three things. Again, in Lewisham, I wondered about, so there's dialysis, but there's also transplant and transplant lists. So you had a very good idea of encouraging more kidney donations, but that wouldn't guarantee that those people would get those kidneys, because in the U.S., we have problems of how people have been on the transplant list, even the way that the glomerular filtration rate has been adjusted for race for a while, which made people with bad kidneys look like their kidneys weren't so bad if they were black, because I guess we're supposed to have superpower or something. So anyway, so all of this, it's about going and plugging it in and then plugging it somewhere else and then flipping the switch, right? So more kidney donations won't necessarily get it, paying attention to how people get on transplant lists and how long they're on them. And so it's a lot. And I think that is so good. You've done the first part, name the problem. I'm sure people have known about the problem for long, but here in our context. The second thing is, to you, Graham, don't step back if this happens again in 6 months, but you can bring others here. But what this is doing for you is you are a listener. We had a conversation on Friday, and you keep talking about listening, so you need to keep listening, but also it's about accountability. Mm-hmm. So if you don't come back to the next session, then how are people going to hold you accountable? How will you even know what people want to hold you accountable for? Now, if you don't want to be accountable, then the easy thing would be to send somebody else in your stead. But I think you do want to be accountable. So I think you should come here and somebody else, somebody from the community. So, so expand who's here. But I would say don't step back, because I have appreciated your earnestness and your listening right now. So
thank you.
Yeah. And the third thing is about people who are living as white using their power. Not even as an ally. People talk about allies and stuff like that. I think of it as patriot or something like that, because racism is not just hurting those people. There are people who are unfairly disadvantaged and people who have reciprocal unfair advantage, but it's hurting the whole society. And so I think that white people who would do anti-racism need to speak up. They can be the first one. They don't have to back somebody up. You know, they can be that we could take turns in leadership in that. You will not know what I'm talking about at all, but I'm going to tell you, there was something that happened 10 years ago in the United States. Some 13-year-olds were going to a swim club in their neighborhood to have a birthday party for one of the 13-year-olds. They were people of color. They went to this club, and most of the people who were there were white, and the white people called the police. And the first thing we heard about this was we saw videotapes of a police officer dragging a young black girl by her braids and then sitting on her back. We saw the young black boys sitting on the curb with their hands cuffed behind their backs. So then I asked people in the United States, everybody will remember this thing because it was quite an image unless you were too young. I said, how did we know about that happening? And people said, oh, social media. I said, but how? I didn't know how until the next day when I heard a young white boy being interviewed by TV who was part of the party and was saying, it's almost as if I were invisible to the police. Now, he was part of the party. But his invisibility to the police, when he recognized that, he could have either run home for safety, but instead what he did was he stood there, invisible to the police, and videotaped everything that was going on to his friends. So this is just to know that if you have white skin privilege that's making you invisible to the police or making you super visible to other decision makers or whatever, to recognize your white skin privilege, don't say, oh, I don't have it, don't give me that. Recognize that you do, because it's a system. You didn't try to get it. You're not entitled to it, but you got it. Right? Recognize that in the system that we're living today, you have it, and then use that, as somebody said, as several people said, for good.
Wonderful. Thank you so much. We now have some refreshments outside if you'd like to join us, but please join me again in thanking our wonderful speakers today. And thank you all for coming.